From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the article, Small Bites versus Large Bites for Closure of Abdominal Midline Incisions, a randomized clinical trial. We are here with two of the authors, Dr. Eva Deerenberg and Mr. Rudolf from the Department of Surgery, St. Francis Hospital and Erasmus Medical Center, Rotterdam, the Netherlands. Thank you for joining us, and I'm really excited today to discuss a very important long-term follow-up from what I think is one of the most major randomized clinical trials that in recent times we've had in general surgery, the STITCH trial.
Thank you so much for having us.
Yeah, thank you.
Great opportunity to talk about the trial.
Well, today what we're really talking about is we're talking about how to prevent incisional hernias. And I'd like to start with a frame of reference for our listeners. And one of the metrics in the opening of your paper, which really got me, was in the United States, over 600,000 incisional hernia repairs are performed each year, with healthcare costs approximating $9.7 billion. This is a real problem for our patients.
It definitely is, and therefore prevention of the occurrence of incisional hernia is of utmost importance.
Agree. It really goes with the saying, an ounce of prevention is worth a pound of cure in this case. And to start, actually, I think we should remind our listeners about some of the details of the STITCH trial. This trial was conducted between 2009 and 2012 at 10 different hospitals in the Netherlands and included 559 patients. Can you describe to us the two different interventions to which patients were randomized?
Yeah, so what we did was that we compared the most conventional closing technique of the midline fascia after laparotomy to a new technique. So the most conventional technique was the loop suture, the one on a big needle, and then just taking big bites, taking big steps, 1 by 1 centimeter. And then we compared it to the new technique that was introduced by the Swedish surgeons. That consists of a much smaller needle with a 2-0 suture, which is a single suture, and then we close the fascia with small bites and small steps, 5 millimeter by 5 millimeter. So you distribute the tension over twice as many stitches. And also it's very important that you only try to approximate the fascia so that in your bite, there's no subcutaneous tissue or muscle, of which we know that will get ischemic when there's a lot of tension on it and probably will increase the rate of incisional hernia.
One of the questions I had, I was like, oh, well, what about the suture ratio? But you guys maintained a 4-to-1 suture ratio for both techniques. Is that correct?
Yeah, that's very important. We asked during the trial for the OR nurses to count the stitches while surgeons were suturing so that you could correct during suturing. And then we measured at the end the remnant of suture that was left and compared that to the ratio that was reached. And if it was below 4, we advised to redo the suturing. Of course, it was 3.6 or 3.8. That was okay. But if it reached like 2, people reclosed, which was not very often. It just takes you a few times measuring yourself, and then you get a feeling of when you reach 4-to-1. And actually, it was easier to reach it in the small bites technique.
I can imagine. And I just want to commend you on the level of detail for that study. It's really admirable. And so this paper, the one we're talking about today, actually represents a very impressive 13-year follow-up of those patients. Can you start just by telling us what were your main goals and primary outcomes used for this study?
Well, the primary goal was to assess the long-term cumulative incidence of incisional hernia across both randomization groups. Most studies only take into account 1 or 2 years post-OR, post-surgery, and therefore mapping the whole duration after surgery greatly improves our understanding of the etiology of incisional hernia formation.
And how did you actually evaluate these patients over the course of 13 years to evaluate for the recurrence?
So they all gave informed consent for a long-term follow-up in the original trial, all patients did. And then for all the patients that died, we looked at all the available medical charts. So all imaging, all chart reviewing, all OR notes to see if they had a mention of an incisional hernia. And all patients that were still alive were contacted for follow-up, and they were all invited for an ultrasound and for physical examination.
All right, so not all of our listeners may have had a chance yet to read the paper. So let's go ahead and get into your major findings. Can you recap those for us? And did any of those findings surprise you?
Well, at 13-year follow-up, the cumulative incidence of incisional hernias in the small bites group was around 36%, and in the large bites group, almost 50%. So that means a reduction of almost 50% over this long follow-up period. Furthermore, the incisional hernias that were present in the small bite group were smaller than those in the large bites group. And I guess we were surprised by how durable the effect was. The Kaplan-Meier survival curves diverged early on at 1 or 2 year post-OR and afterwards stayed parallel for more than a decade, showing the protective effects that the small bites closure had on these patients' abdominal walls.
And what was really striking is that patients that were closed in the conventional way, which we have done for decades, half of them developed an incisional hernia, which is horrible, the amount of patients that develop an hernia. And what was also striking is that we looked into quality of life of those patients because some of the comments we got was like, are those incisional hernias really symptomatic? Do those patients really care that they have a hernia? And when you look into the quality of life measurements, you see that patients with an incisional hernia all had a lower quality of life. So yes, patients really care they have a hernia. So it is an incidence study. So there are some asymptomatic patients there, but the majority of patients really has complaints from the hernia.
I had the same reaction when I saw 49% in the large bites group. And especially as an emergency and trauma surgeon, our rates of hernia in general are higher anyways. So this was really eye-opening. And the other thing you touched on, Rudolf, that I want to go back to is that even the hernias that developed in the patients that underwent the small bites repair had different characteristics than the hernias that developed in the patients with the large bites. Can you expound on that?
Yeah, so the hernias that did occur in the small bites group were significantly smaller, and over time they progressed way slower, if they even progressed at all. While in the large bites group, we saw that many small incisional hernias continued to grow and grow, leading to the large bite incisional hernias also on CT containing more tissues such as colon or small bowels, while the small bite incisional hernias only ever contained fatty tissue.
And the size that we're talking about here is 2 centimeters. Is that correct? Where we're kind of seeing this difference in the small bites hernia group versus the large bites.
Yeah, so that's true. Most of the small bite incisional hernias stay below that 2 centimeter width mark, while the large bites group expanded well over that 2 centimeter mark.
Yeah, so when we were looking at the CT scans, we saw those enormous large hernias, but we also saw those like small buttonhole hernias. And we're like, those are not the same disease for the patient. So that's why we decided to also look at that cutoff of 2 centimeters, which we found clinically relevant. So below 2 centimeters and just containing some fatty tissue is something different than a big hernia with your bowels incarcerated later on. And then the effect was even much bigger. So the small bites group, patients that were closed with small bites had less hernias above 2 centimeters than in the large bites. In the large bites group, almost all hernias were over that threshold.
It really goes to show that the technique matters not only initially, but down the road. Because again, we're also talking about quality of life. And I think that's something that we often can underestimate, especially for, surgeons. We see lots of hernias. We are used to seeing the CT scans with the colon and the small intestine and so many things in them. But it's important to really remember, and thank you for highlighting that any patient with a hernia had a lower quality of life than a patient without.
Definitely. And a lot of our patients that were included had malignancies of the gastrointestinal tract or gynecological malignancies. And you often see that they don't complain to you about their hernia because they're very content that their cancer is cured and they won't complain to the doctor, but they still are very symptomatic from that.
One thing I did notice in your paper that I'd like to talk with you about is this study was performed in the Netherlands, and the average BMI of participating patients was 24, which does seem to be a little bit lower than what the average BMI we encounter here in the United States for these types of surgeries. What do you think about the durability of your results in obese patients? And do you have any practical or technical advice for those of us in the United States operating on patients with larger BMIs?
So we get asked this question a lot, and the median BMI in our study is indeed around 25 for both groups. But we did do some subgroup analyses of only patients with BMIs exceeding 25 and 30 and saw that the small bites technique had the same protective effect in these groups on incisional hernia occurrence.
Yeah, and when you are closing somebody that already had a laparotomy, so a relaparotomy, or somebody with a diastasis due to their high BMI, you could take some larger bites. Just be sure that you don't take the fatty tissue and the muscle in your suture. And it's very important, I think, that you take a lot of steps so that you distribute the tension over a lot of different sutures. And then the technique is still very feasible in high BMI.
That's really helpful. One last question for you. So the small bites group had a lower incidence of incisional hernias, but it was still 34%. Now, this is a well-designed study, very high quality. You guys monitored everything in the operating room when the stitch trial was performed. What do you think are next steps? It seems like we still have room to grow, so to speak, or room to improve upon this incisional hernia rate. What do you think are next steps in research?
So in my opinion, I think that it has been proven that using a small bites technique and a meticulous closure is the best way to close your patient, even if you had a midline laparotomy in an emergency situation or a higher BMI. But I think research for the future should be focused on other prophylactic measurements we can do, which can be surgical technique, but also rehabilitation for those patients.
Well, this is such a great article with real, practical, technical information every surgeon can start using today. Dr. Deerenberg and Mr. Vandenberg, thank you for joining me today to discuss your article, Small Bites versus Large Bites for Closure of Abdominal Midline Incisions, a randomized clinical trial. Our listeners can find a link to the article in this episode's description. This episode was produced by Daniel Misisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Have a great day.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.